NICAT press briefing as well, so you follow how well we've been trying to educate each other as to what the virus is, what the other outbreaks are, and what we are dealing with in the country. Liberia has experienced monkeypox in the past, so as you know, this is not the first time. But this new situation of mpox, as declared by the World Health Organization and the Africa CDC as a health situation of international and continental concern. Here in Liberia, we have taken it very seriously. As you know, we did not have the mechanisms in place to respond to threats as such during Ebola, but we did put in place such mechanisms after Ebola. But during COVID, during the COVID pandemic, we were in a way relaxed, and it caught up with us. Taking our experience from that end, and based on the experiences collected by all of our teams, we decided to go ahead of what we're facing. That is being as proactive as possible in order to address the outbreaks that we've seen sporadically, cases that we have seen sporadically, and address the continental and global outbreak that has been announced by the WHO and the Africa Centers for Disease Control. Since the announcement in mid-August of this year, 2024, we have had 11 cases, and but since January this year till now, we have a total of 17. I just wanted to make that distinction. Since January till now, it's a total of 17. But since the outbreak was announced in August by the WHO and the Africa CDC, Liberia has 11 cases total. And we will break that down for you. Currently, we can announce 3 new cases since we last announced the previous new cases. In between, we have observed some caution in order to continue our trainings. There have been series of trainings going on, epidemiological response training, diagnostic response, collection, training our diagnostic personnel in proper collection of samples and proper packaging of samples, as well as rapid transfer of samples to the National Reference Lab for detection. And that has been going pretty well. Currently, we have teams in the various counties that are supported by USAID, the WHO, AFINET, the CDC, US CDC, the World Bank, and other partners that are helping in collaboration with the efforts that we are mounting in order to have our workforce, response workforce, trained and then refreshed in their duties. And so that training is ongoing throughout the various counties. You probably might have seen some of our teams report on their adventures, the journey towards Grand Crew, where we have seen cars stuck all in the mud. In September, when we went down to Secretariat, we faced the same situation. We were all stuck in the mud, and we emerged out of there. So in between that, we also had some of our epidemiological response force being trained in medium, intermediate level FETP, which we call Field Epidemiology Training they've been trained in that respect as well. One of the major trainings that we have had also is the sequencing training, and that will give us the answer that we are coming to later on that you probably may ask, or that we will be the announcement that we will be making, which is a major one. That allows us to have in country the necessary technical ability to look at, detect and look at the genetic mapping of what monkeypox virus variant we have circulating in Liberia. Before coming, we have limited capability in that respect, and our partners, particularly WHO, through our request, made particular efforts in having a team coming in country, a team from Ghana that we are pretty much familiar with, headed by Dr. Bright, and to carry out training of our diagnostic research technical folks that we have here. What they have done is we have technical personnel that know about sequencing, meaning know about doing that test that can give you or show you what the genes look like of the circulating virus. But what we didn't have was the end point where now you are able to do the analysis to actually see the genes. And that is that biostatistical aspect and that we did lack. So they're giving us, building up our technical capacity to have that particular force here. And so that's one of the training that is going on, and that's happened going on in between. So in between, that's when we had these 3 cases. We did not want to immediately announce them. Why? Because in the meantime, 2 of our partners, the WATCH-NPHIL and the WHO, had made some arrangements for us to send out those samples that were tested positive, right? We send those samples out. And some of those samples that were tested negative were also sent out in order to know what clade we have in Liberia. Mind you, at the time we haven't had this training going on for the sequencing, so we had to send them out. So we sent some out to our sister entity, the Nigerian Centers for Disease Control, and we sent some out at the National Institute of Health in the United States of America. The first results came from the Nigerian CDC, Nigerian Centers for Disease Control. We did not want to release it because given our own scientific principles and analysis, you want to wait for a comparison before you are able to make a clear determination as to what you have. So we waited for the sequence from the United States to come. Fortunately, we have got a series of results coming in, and we got a first batch, which tells us now what we have. So given the 2 batches of sequence data, sequence results that we have, we can announce to the public, to the professional community, and to the public health community, particularly thanking the Africa CDC and the WHO with which we collaborate on these matters. We are here to announce that Liberia has clade 2A. So Liberia has monkeypox virus clade 2A circulating in the country. Now, much of what we have been seeing has been sporadic. And so, given the sporadic nature, our strategy has been, whenever we see a detection, we mount every effort in containing it, isolating it, treating, and ensuring that We do contact tracing to know who else this case came in contact with and help to isolate those ones so as to avoid the virus translating from person to person and from community to community. That's the whole essence. And so when we had these detections, the first one somewhere in Sino, which was a very hard to reach area, we did the best we could, and thanks to our Sino team that had to traverse very treacherous jungle terrain, high forest terrain to reach the areas where these cases were. And they did the best. They isolated, and then because of the lack of actual isolation centers there, they improvised and did a home-based isolation and home-based treatment. And we were able to have that situation under control. So presently, out of the 11 that we had, as we said, among those 11 were 2 new cases that we had, 2 from Bonn and 1 from Basel. The 2 from Bonn, 2 confirmed cases, recent cases from Bonn. As we said, we have 3 confirmed cases recently. It's a 1-year-old and a 2-year-old. 1 month, excuse me, 2-year-old and a 1-month-old. As the briefings came in from our acting director of the Division of Infectious Diseases and Epidemiology, Alberta, who sits here, the mothers created a kind of situation which is very concerning. Apparently, from the case history that was taken, both mothers had symptoms of monkeypox. Some of those symptoms, which include, very overtly, we will just deal with that very visible one, the rashes and those bumps with the pus in them, which can dry up and form crust scales. In dermatology, we call scales, but in other epidemiological language, we call crust. But it's not rice crust. But since it resembles that, it's difficult to kind of scoop out. We term it as a crust. So that's something like that. They had similar symptoms, only to know that their symptoms resolved. And as you were here the last time, and repeatedly during our conferences, we tell you that the disease itself is what we call self-limited, meaning you can have it, and because of your body's immunity, as strong as your body is, your immune reaction, you are able to beat it down. You can be healed. You can be healed. You can recover. But we don't want people rely on that and staying home just in case you find out that you have those symptoms, and then you say, okay, since I can recover, I should stay home. But that's the kind of attitude that the 2 mothers adopted. But our team were able to, detect and that there were these suspected cases, which we then saw that became confirmed as a result of laboratory testing. So they transferred the virus to their children. So you see why we say avoid contact. Now, these babies are in close proximity with the mothers. So you can imagine with that close proximity, the contact is there, and so the transfer and transmission is easier. And that is what happened in this case. Now, like we said, for most of our cases, they are then sporadic, meaning they are not coming out so fast in every county, everywhere in the country. We've had 1 coming out or 2 coming out in as far as Sino, then 1 in River G. Then you look all the way up north in Bonn, North Bonn, and then Lofa. You see these other few cases. At one point, we had 2 cases in Lofa. So what's happening that these cases, they are not, they are along these lines. But take one thing into consideration. What we, our epidemiologists here term as epilink, meaning trying to get, find a linkage between the case and where it comes from and where it may be going. We are seeing that these two counties or these two regions, they are bordering countries where we have monkeypox as well. So take Rivergy, Sino, Rivergy, Maryland, Grand Gila. They're bordering the Ivory Coast. So in the Ivory Coast, we have a lot of monkeypox virus transmission and mpox cases. Now, you know how people cross the border. So we suspect that this must be a cross-border, for the Maryland and Rivergy, a cross-border transmission. But then for Sino, what we noticed was that the father is a hunter, and that's a deep down forest area. So he may have caught, he may have brought it from any of these animals, the monkeys, the squirrels, for which we call this virus and its family the zoonotic viruses. So that means they come from animal to animal, animal to animal, then animal to human, then human to human, human to human, and that's how the transmission goes. So that's why we suspect. Similarly with the case of Lofa, it was pretty much the same, but we also suspect a cross-border transmission because we were also alerted at some point by the Prime Minister's office in Guinea that there was a case of monkeypox, detected monkeypox patient coming towards Liberia. To this date, there's somewhere in between there that their agents have not been able to locate that person, that patient. Our agents have still not been able to locate that patient. But you can see, and in Lofa, one of the cases were reported to the clinic, was detected in the clinic. So it suggests that something is going on in the communities, and we were not at the time picking that up. So when we noticed that pattern, we beefed up our surveillance, and we were able to be more vigilant, monitoring the situation and detecting cases. So for the case in Bassa, so that's the case of these two that we saw in Bunk, right? Where the mothers transmitted the virus to the children, the 1-month-old and the 2-year-old. They are not coming down with symptoms. Interestingly, the 1-year-old mother, the 1 month, excuse me, I keep saying 1 year, the 1-month-old mother cannot be found. Because once they knew that we had our agents, our detectives, they then, because she told, according to what we gathered from the history and our surveillance, that the 2-year-old mother, because she got healed, she told the other one that you will get healed of this, so you don't even need to report to the clinic. So in that respect, they knew that there were disease detectives, from the NPHIL looking for them. They immediately escaped, and they cannot be found presently. But we still have the case being actively pursued, and we look at contacts that they may have come in connection with, and we are pursuing that. Now, we have to do this because in order to reduce panic in the community, panic in a society. As you've seen how the NPHIL has been handling this outbreak, we have been handling it with full force. This outbreak that was announced by the WHO and the Africa CDC, from all indications, all right, we have all these cases so far. If you look at Nigeria has about 1,000+ cases and several hundred deaths. And we have this travel between Nigeria and us. So that's a possibility of cross-border transfer. Now, when you look at Kenya, all the way up in the central part of Africa, right? Kenya, according to our last DG's meeting, all the Director Generals, we have a meeting with the Africa CDC every Thursday, and we report. Liberia has been reporting, and we'll come to that. They have 13 cases. Kenya has declared ever since an outbreak. Here in Liberia, we have done everything possible from our professional standpoint to advise various government entities that this particular situation equates to an outbreak. Again, it equates to an outbreak when we have just 2 cases detected after the announcement was made. Because the manual says that just 1 case, given the nature of the virus, just 1 case is an outbreak. And that is why when the world started seeing these cases all around Africa and then in America, in Europe, they immediately declared something like, they say around the world something is happening. They did not declare pandemic, but they are telling us that it's a global concern, and also it is of continental concern. So we can say it is of national concern. The WATCH-NPHIL and ECOWAS can say it is of regional concern. Mana River Union is saying it is of sub-regional concern. So we have to take it serious. Note that there were many people who denied that COVID, was real. You press people follow that. Even medical people denied that COVID was real, only to know that COVID was killing people. And it was so sad that even people of medical background were also denying that. We hope that is not happening in Liberia, that people of high professional medical background will deny that mpox does not exist, for example. We are asking the public to take it very seriously. Mpox is a virus. We're seeing what's happening in the Central African republics, meaning Burundi, Rwanda, Central African Republic, Kenya, Uganda. They are heavily hit. So we are advising you to take it very seriously. We have an mpox situation on hand that the world and the continent has declared as an outbreak. Take that very seriously. Maintain your distance from anybody you see who is having symptoms of those rashes, who's having symptoms of those rashes and those bumps on their hands and in their palms and on their face. We have seen several cases of that already. And so we want you to take it very seriously. So again, to state, Liberia has Clay 2A, and because of public health accountability and transparency, we are under professional obligation to announce that this is something that we sold to the Africa Centers for Disease Control and WHO to do. It is through that they get the data that they need to see what's happening in your country in order to channel help to your country. As you know, most of what we do is dependent on donor assistance and all of that. So if I don't know what's happening in your house, that your house is leaking, you can't ask me to put zinc on top of your house to stop the leakage, on your roof. Unless you say it, that's the only way I will know what help to give you. And that is why these things are for. The second reason is that knowing the clade that circulates in your country gives us, the scientists, epidemiologists, and all of us, the idea as to whether the vaccines that will be sent can cover you. Because vaccines, they are meant to prevent diseases, right? So the first time, if you have clay 1, and they made a vaccine targeting clay 1, now you start having clay 2, and clay 2 start having 2A, 2B. That vaccine that was for clay 1 probably may not cover clay 2. So then those who produce the vaccines, they will know that, okay, in Liberia, in West Africa, this is the major thing that is circulating there, the major clay. And in this other part of the continent or the world, this is the major clay that is circulating, the major type, all right? We can call it type. Clay is just type, variant. There are many different synonyms for that. So then we go back and redesign the vaccines. As you see with COVID vaccine now, COVID vaccine is now multi-variants, right? It covers the different types of the COVID that we have had over the years. So so is the monkeypox vaccine. They're trying to also develop it and make newer ones as we are able to announce newer, detect and announce newer clays. The third thing is, so the first thing is, once you announce, people will know then how to give you help. The second thing, the vaccine people will know how the vaccine can cover you, right? And cure your people. The third thing here is diagnostics. Through that, those of us who design these diagnostic tests will know, okay, the first diagnostic test we designed, it was for this particular clay. Can it detect this next one? So it gave us the idea to go back to the drawing board and look at the genetics and look at everything else, molecular, and redesign, so that when the kids come here, they are not giving you false negative results, meaning you have positive cases, but because the kit is not designed for that, right, it doesn't see it as positive, it sees it as negative. Because this detective was shown to go and detect people with red shirts. Now, you have people with, little bit pink shirts coming up. When it comes, it will just go strictly for red shirt. It will leave those pink because it says, well, the only two will come for red shirts. That's the same kind of thing. So, so that's the third important reason why we need to know the clay that is circulating in Liberia or in our region. Then in our region, it helps us to know, in terms of transmission, what we should expect in terms of cross-border transmission, what we should expect. In Nigeria, for example, we have clay 2 circulating there, and predominantly I think it's clay 2B. Here is clay 2A. So again, that helps us. The fourth reason why we need to know the place is that helps us to know also where it's coming from. It helps us to know that lineage, where it's coming from. So when we do the genetic analysis, we are able to build a tree and see, where it is coming from, how it changed itself, it mutated, and how it landed here. So in our country, once that is done, we will build that genetic tree and say, this is what we have. It may have come from this lineage until it got here. So it helps us, all of us, to understand how to mount the response. Because the fifth reason, whatever it is now, the fifth reason, it helps us to also know whether, when we are treating it, whether we are able to, the medication used to treat it can also treat this clay 1A, and it can also treat clay 2 and 2B, 2A, and all of that. So that's another. So there are multiple reasons why the world, the scientific world, the public health world, the medical world is interested in knowing what is circulating in your country. So I will jump to another situation that occurred in recent times, in the last 2 weeks, one week and a half or so. Last 1 week and a half or so. Presently, in the Democratic Republic of Congo, particularly in Rwanda, there is the Marburg outbreak also. Marburg, M-A-R-B-U-R-G, Marburg. M-A-R-B-U-R-G, Marburg virus. There was an outbreak in Rwanda, and several healthcare workers have been infected. They're still trying to find the source of it. because it's not like most of the infected persons are healthcare workers, so they are not seeing like people in the clinic transmitting it to healthcare workers, but they see healthcare workers being transmitted, being infected coming to the clinic. So they're still trying to find that actual transmission pattern. And we have several students in Rwanda, so we've been concerned about it. Here at NPHIL, we are not only looking at Mpox. Mpox is just a new thing that came on our table. We've been looking at measles, we've been looking at Lassa. These two outbreaks have been going on. Now with the announcement of Marburg outbreak, we are also concentrating on that. Regularly, since we have Ebola in this country, we have regularly tested for Ebola. We have regularly tested for Ebola. Every week, we have results coming out from tests of people we suspect to be having Ebola and Marburg. So when we heard of this, there's a passenger who came through Liberia from that area, from Rwanda, and had these symptoms which look like malaria symptoms, fever, headache, general weakness, and all that. And this patient took some drugs, to help themselves wear away. But then they got scared because they knew they came from that region. So once the case history was given to us, we immediately mounted a response. That patient was isolated. Samples were taken and sent to the lab. It was on the weekend, and as we have said, our work here is not a 9 to 5 work. Our work here is not a Monday to Friday work. Our work here is not, we can be having Christmas party and we can leave for there and go do laboratory work. So that's the kind of technocrats you have around here. So that weekend, our people were on that. Dr. Gideon, Alberta, and the others mounted that response. We saw that after the test was done on the weekend, the test came out negative. So we said, thank God. At least that scare of Marburg, which we have been testing for regularly along with EVD, Ebola virus. Thank God the person who came from that region does not have it. But we didn't stop there. We are monitoring that person, that patient, over the next, it's already seven days. We are monitoring it over the next 7 days, taking 14 and then 21. To be cautious, very cautious. And that's the kind of diligence that the folks here gave to the work. And we will continue working in that fashion so as to ensure that our country is secure in terms of public health. I want to thank all of the workforce here that have been mounting all this response, taking up your precious time, the evening hours, these laboratory personnel. Some of them leave from all the way Brewerville for 5 a.m. You know the Douala traffic. They come here, then they have to leave from here to go all the way to Charlesville. I mean, that's the kind of dedication that we are seeing, and we continue to encourage. We hope that government agencies responsible for personnel, government agencies responsible for health care in general, will take note of all of this and at a particular point in time provide the necessary incentives and compensation for these workers that so daringly sacrifice their lives for 5.2 million people nationwide. So I'd like to stop here, and if any of our colleagues have any other subsequent update to give, we can have it, and we can answer your questions.
Okay, thank you, DG, distinguished colleagues from the media. The DG will now entertain questions. As usual, you call your name and your institution and you pose your question.
Thank you, DG. My name is Bill, and I write for Inquiry newspaper. Now that you have the disclosure of the kind of virus we get in like US is the report, which is the 2A.
Yes.
I'm a little bit concerned about the nature of the virus, whether it is deadly or threatening virus we have in this play 2A. I'm really concerned about that. And then lastly, you talked about the issue being bone counting, the lady that is on the bone. Now that we are aware that she's a carrier of the virus, and then she will come in contact with other people. Swift, your team, putting himself to be able to ensure that the necessary division of the issue of the spread.
Okay. Clear 2A we are following presently. We just got to know that we have it. We are now going to see what we have now seen so far is that all of our patients who were infected with that, before we got to know that it was that, they recovered. All right? I mean, I say all specifically because we still have about 5 active cases. But those, we don't have any deaths. That's the point I wanted to make. So we have a lot of recovery, 6 recovered. 6, that means the 6 after we just want to concentrate on after the proclamation was made, right? That declaration was made by the WHO and Africa CDC. So out of these 11 active cases, which included the 3 new ones that we have 5 now active, meaning 6 recovered, and we have no deaths. So it tells us, and we don't want to be relaxed, right? It tells us that the behavior of this virus is a little different, but we don't know what the immune status of those patients were. If they were immunocompromised, meaning if they were people that had, like, just say tuberculosis or AIDS, it would have been a different thing. But from what we see of our data, it's affecting mostly children, all right? From the actual data we've seen, it's affecting about 33% of children. And that is the trend around the world. Or the pediatric population is heavily infected. So that's what we are seeing. Now what we're going to do is to follow it and see how it behaves in the patient population. The second question was the case in Bonn. The second question regarding the case in Bonn, as I stated, our team is doing an active now. They have to redouble their effort to do an active case search. Usually we do active case search, but you have to be active to the second part of case search. Yeah.
Okay, yeah.
Thank you, Dad. My name is Trukon Floma and I work for Spoon Network.
Ah, Trukon, how are you?
Okay. The other day we were here, you spoke of efforts being made for vaccine for mpox and other diseases. I don't know how far. Can you please bring up to speed?
Thank you. We did put in for treatment for Lassa, the river variant, and that is en route to be sent to Liberia. The WHO has done quite a tremendous job, thanks to W.R. Clements and his team. We will soon be receiving that. We also put in for vaccines, verbal request, when I was 2 times now on the Africa CDC's, the Regional Generals meeting, where we presented on 3 different occasions. And they asked Liberia to put in a written request that Liberia was in line to receive, because our case to them was the fact that we are having these smaller cases, we need to start vaccinating so that we form a ring around the rest of the population. And they bought that idea. So they are saying that irrespective of the fact that they are giving a lot of vaccine to the heavily infected countries, they will also send vaccine here. What we want to do is to coordinate with the Ministry of Health so that we don't put in a double request. Now, if it is that from the Africa CDC side, are you listening to me? Mm-hmm. Okay. You like you relax, that's why. Yeah. So there are 2 avenues. maybe the MOH has that possibility of getting something from somewhere, and NPHIL has the possibility of also getting something from somewhere. If that is the case, we'll get a lot. But if that's not the case, then we need to put our request together. Meaning, if it's coming from the same source, then we have to combine our request and then submit it as one request from Liberia. So that's something we'll be working on with our collaborative relationship with the MOH.
Thank you.
My name is Tina Smith and I report for the Daily Observer newspaper. How are the patients recovering?
How are they recovering?
Yes.
Well,
since we don't have vaccine in the country.
That's good. As we said, number one, the disease is self-limited. Number two, they're under symptomatic treatment.
You say self-limited, can you just...
Self-limited, oh yeah, you're right. Self-limited meaning the body can fight it and you can be cured, you can recover.
Right.
Just like the two mothers that recovered, but they transferred it to their children. You see? So one of the mothers started telling the other mother, don't worry, man, don't go to the hospital, you will get killed for that thing. You know, which is wrong, all right? Because you can never tell. So that's what we call self-limited. When the disease, the body can fight it. It's just a cold, when you get fresh cold, right? If you take medicine, you take a lot of water, food, where your body can wear it away. So that's one. So then we use symptomatic treatment also. Given the symptoms they have, we give them the medication for that.
When they got fever?
When they got fever, you give, paracetamol, or in some other countries they call acetaminophen.
So each of the recovery is based on the symptoms they have?
Certainly, and there are medical, kind of paste that is, rubbed on ointment or paste that is rubbed on the patient to address the bumps. What in medicine we call vesicular papules, those bumps that have the pus in them. So that it dries up and then it becomes scaly, which we call crust. And as soon as you start to see, you see those dry up scales, then you know the person. Those are the signs of recovery. Otherwise, if the person is not recovering, we as humans, you will certainly see they will continue to be weak, continue to have fever, and those bumps will continue on until, in many other countries, until the person succumbs and passes away. But we have not had that situation. We have 0 deaths.
Yes. I'm still once we get these are start with Liberia. Yeah, Dr. Young, you measure for cases in the southeast called Sano. How about cases in Maryland? We address that.
Yes, we again in the southeast we've seen these cases, and the cases have been, isolated, some on a home-based treatment, and they are improving, as we've heard from our incident management system meetings that we have here now every Friday. Reports emanating from those regions indicate that the patients are responding to the treatment and they are improving. We anticipate that we may not see any death, and we continue to have 0 deaths in Liberia, suggesting that we are properly managing our cases.
Okay.
Yeah, I'm Lincoln H. Dahlia. I represent Analyst newspaper. Interestingly, NPHIL is doing well by updating Liberia on all of the outbreaks that are taking place. And so we'd like to know, what are your strengths when it comes to finances in order of making sure your team from rural counties are effective on the field? What is your strength when it comes to finance? Is it that you are getting support from the national government or from the international community?
One of our strengths has been the strategy that we have designed here. I think that's one of the major strengths. You can get millions of dollars if you don't have the strategy to fight back, it will be a waste. So that's why I continuously thank the team here for us listening to each other. We sit here, talking to each other, designing strategies. Then we come to the meetings we call the NEPRC and the IMS, these incident management meetings, and we we don't yell at each other, but we can really talk hard at each other about what number you put over there. Is that correct? Is it not correct? Or what can we do? Some people will say we need to put more people in that other place. We need to shift this place. We need to train more people. So we put all those ideas together, then we start to implement. So I think effective implementation is another key strength that we have. Another key strength we have is our ability to really talk to our partners and they listen to us and help out. So AFINET that does a lot of the trainings for our flea epidemiologists, or the United States Centers for Disease Control that help out also in diagnostics, in flea epidemiology, WHO with the help they're giving us to know what claim we are having here, the sequencing thing, and now we are training our own people to be able to do those analysis from point A to Z. So we have that capability in country. The only thing we'll continue to do is still send samples out to verify. You know, that's how science is. So I think these are three key strengths that we have. One other strength I think we have, which you have just acknowledged, and thank you very much for that acknowledgement, is our ability to continue to communicate the awareness with which all of our partners also have been helping with USAID, UNICEF, GIZ, UNC, Africa CDC, and all of our partners. So I think that good, collaboration, understanding what needs to be done, constitute our strength.
Yes, sir.
Yeah, my
If I don't add this, I'll be in trouble with my two sisters. One major strength also, I think, is the appreciation that has come from the national government, represented by the Health Committee of the Senate and the Health Committee of the House of Representatives. So that's Senator Vapila and Representative Julie Fatuma Weir. We've sat with them on their invitation and on our communication, and they asked us, what do we need? And that was immediately when we started reacting to these first two cases when the announcement was made. They immediately saw what we were doing, they called us. So from those discussions, they advocated for a budget line to be included for the response. You may have read in the papers that NPHIL given 500,000 to 1.5 million. That was the projection. But to date, they have actually allocated 380,000. We have not received any money from there. And let it be clear, we have not received any money from there. We are still running after that money. And I know Sister Julie and Sister Daba will help us to get our money.
How you gonna do?
Yeah, my name is Ralph and I report for Vision TV. What if one have a symptom and then don't want to go to hospital? Is it helpful that one will use the Gojolobo sign to drink or rub the chalk on them, quarantine themselves for a number of time? Is it helpful for them?
It's not. We advise you with modern medicine now that today we have people who will know what's happening and know what to do. We advise that such persons report themselves to the nearest health facility so that they can be properly taken care of. Instead of drinking herbs, which efficacy, which effect, we don't know, meaning the strength. I mean, we know sometimes those things, the effect, the side effects can damage your liver. And most people don't know that, but we will advise you to drink yourself or report yourself to the nearest health facility. You'll be well taken care of. Call us anytime on number 4455. 4455. It should be active now, I think by now. Yes, that number is active.
Okay.
Yes, well, my name is Kupos and then I report for Truth FM. And my concern is about awareness. In the absence of awareness, there will be some level of panic in Liberia. I still to look over I'm here to hear on community radio stations of awareness by NPHIL. How far is NPHIL contemplating on raising awareness on various community radio stations?
Again, there have been a lot of jingles played on various radio stations. I don't know which one you listen to. True FM is my good radio station anyway. Yeah, I go there, they call me every time. So, on various radio stations, frankly speaking, UNICEF has done quite a good job to create those jingles in recent times. You know, this is a dynamic process. As he said, we've been doing a lot of the radio move around. Even before I became Director General, I was on True FM many times, sometimes right, and we spoke about that. You heard the people calling in from where we had to direct some people at SOS, which is right next to us here. So the problem is that we have to increase the volume of messages. But there are messages, there are posters around the various counties. The WHO printed a lot of posters and flyers. So we then distributing them in the counties. You know, because in the counties, there's not much facility to print those things. So we start from behind to come up. Because Monrovia is not Liberia. So that's the approach we've been taking. So I believe much has been done. ELBC carry a whole, program on just mpox disease. Yeah. Well, the is yeah. Right. At one point, we also indicated that we need to transmit it on in the local vernacular. Yeah, and that suggestion was made. That question was asked when we did one of the awareness at ELBC, and we said certainly we'll do that, and that has been going on. So people in the villages are hearing about this thing here. We tell them it looks like smallpox, it looks like chicken pox, but it's not that. Because the people in the villages know about smallpox, they know about chicken pox. We had these things before modern medicine, so they know about that.
So there are import messages of the local tariffs.
Yes.
Around the country.
Yes.
Sometimes when we sit here, we don't hear some things. Yeah, and we think it's not going on, but it's going on.
Yeah, my name is Aaron. I report for DN News Liberia Online.
Aaron
Cuban.
Aaron Cuba.
Yeah. You might have said something that is causing doubt in my mind, but maybe I may need further clarity. On the issue about the case from Bond County with the 2 kids and their mothers, you mentioned that the mother escaped, and I want to ask as to whether you got specimen from the mother that escaped, because you mentioned in passing that that is one of the active cases. You talk about active, pursuing that mother. So how did you know that that is an active case? And if my doubt is that you did not get specimen to know actually that was a monkeypox, how did you know that is an active case? Okay. And on the issue about the 2 kids, did they also go to the hospital to get specimen for them? Are they being treated as well?
Okay. Our team, during this surveillance, right, they go around in the community because we have had 1 case in Bond already. So they go around, just as detectives, looking for criminal, something like that. That's how we operate too. So they go around doing those things from the contacts that were from the first case they saw. So they keep following these contacts. If they say this person lives here, they go there. Then they follow 2 other persons there. That kind of strategy. So they came across this and saw that this child had these symptoms, right? And the symptoms, these children fit the case definition, where we define it as, yes, this is mpox. So that became a suspected case, right? Without the laboratory test, that's a suspect. Mm-hmm. It's like how you suspect somebody of stealing something, then they got to go to the police station. When they find them guilty, then they put them to jail. So it's the same thing. So they're suspected. Then we take the samples, right?
From the kids?
Yeah. So that's what we did. We took the samples from the kids. Our diagnostic people took the samples and took them to the lab. They sent them here to Monrovia. We did a lab test and found out positive. So that turned them into what? Positive case. So from suspected case to positive case. Now, we know now that these cases are positive cases. So the mothers in reverse become the contact, right? Okay. Now, from the investigation, it became known, the mother said, what my child had, I had it before. You understand? I had the same thing. But now she doesn't have it anymore. So in return, of course, since from the case she had it before, in what we call immunology, we presume that she must have defense, you know, built up in herself already. Nevertheless, she becomes a case to trace in a reverse, okay? Because she could pick up from the child and go to other people and transmit it there, but she will not be sick because she passed through it already. Same thing with the second child. That's what happened. So that's how we knew that these cases now that were positive now become active cases. So you see the difference?
Just a follow-up, sir.
Yeah. Now I just want to make sure you understand the trend.
Yes, I understood what you said, but I still got some follow-up to do. You mentioned, stand to be corrected, you mentioned 17 cases that are since January.
Yes.
The two other cases of the mothers that you did not test, and based on the two kids' symptoms.
So I understand the doubt.
Yes. So they're not included in that number, right? Yeah, that's the clarity I want to get. Okay, thank you.
To clear your doubt, you consider it as missed cases.
Okay.
Yeah.
And there may be missed cases because, like we said, people tend to get ill. It's a common phenomenon, especially in this in our context. Okay? People get sick and don't report. People had it. You saw it with Ebola. You saw it with COVID-19. It's happening. But the key message is, and thank you as the press for coming from time to time to get this information and help us spread it. The key message is, regardless of what we do as laboratories, okay, the community plays a critical role in helping to combat diseases. And that is why when people are ill, they should abide by the messages from the health authorities, comply with us, and ensure that you report on time to receive proper treatment.
Okay, thank you very much. The speakers on this note. We're going to call this press conference close. Thank you for responding to our call. Some of you were in churches. When I call you, we all in this together. The health library help everybody concerned. The director general was planned by the acting general director of service, Dr. Bill Gideona. The lady there is the acting director of the division of infectious disease and epidemiology, Dr. Cover. The fellow there is our Mpox focal person, Mr. Sumo Nolu, and it's flanked by, of course, the HR. She was in service, I didn't probably reading the Bible, how to talk. Yeah, okay, so thank you very much. Again, that you have, as you go by your newsroom, please call us, and we'll make the clarification.
You've been doing very well. Please continue that. Let's continue that.
Thank you, sir.
Right.